All right, everybody, welcome back to another episode of Forward Physio. I am very grateful to be sitting down with Professor Joanne Kemp from all the way in Melbourne. We're at different ends of our days here. It's the evening here, and Jo just started her day. Jo is a researcher and a sports physio as well, but I think that's just scraping the surface with what Jo does. So I'm going to let Jo introduce herself. So Jo, thank you again and welcome.
Hi, Noah. Thanks very much for the invitation. It's nice to be here early in the morning here in Melbourne. So I'm a sports physio. I've been a physio for about 30 years and also work as a researcher at Latrobe University in Melbourne at the Latrobe Sport and Exercise Medicine Research Centre. So we do a lot of research in the field of hip pain, sort of all the way from adolescents with hip pain right through to older people with hip osteoarthritis. So we're talking about hip OA today, so I'm one of the co-leads of the GLAD Australia program, which is a program for people with knee and hip osteoarthritis, but also do quite a bit of work in the space in hip pain in younger people as well.
Right. I think if it was another day, we could maybe talk about some of the conditions that younger people tend to suffer from when it comes to the hip. But yeah, as you said, today's topic is hip OA or hip osteoarthritis, and I think it's a really important condition to talk about because of how prevalent it is, but also how many misconceptions there are about osteoarthritis. And I don't think there's a better person to clear the air with than you. So again, thank you. So I guess to kick things off, how do we define hip OA? I think what most people tend to think of is that it's sort of a wear and tear type of condition.
It's a really good question, actually, and there are a couple of different ways to define it. If you think about it from a research perspective, people often define it as a structural condition. So they talk about what might be considered the disease. So that's where you see the changes on imaging. So you'll see, here it talked about as a whole joint disease. So where you'll see changes to the bone around a joint, to the articular cartilage of the joint. In the case of the hip, to changes to the acetabular labrum and then the ligaments that surround the hip, the capsule. And then you'll also see changes to the, to the muscles around the hip. So you'll see perhaps weakness in the muscle, atrophy or shrinking of the muscle. You might see increased fat content in the muscle, so less muscle tissue, more fat. And then you'll see other changes too, like the person will become generally deconditioned. So, but then we also need to think about it in terms of symptoms. So people with clinical osteoarthritis or symptomatic osteoarthritis have pain primarily, but they'll also have a loss of range of motion and a loss of function as well. So they'll find it hard to do the day-to-day things. And I think it's really important as clinicians that we think about it as the clinical disease. So you might come across people who have in your clinical practice who might have changes on their x-ray, for example, but if they don't have any pain, they don't necessarily have osteoarthritis. I think it's important to understand that the correlation between the things that you'll see on imaging, the structural changes, and then the symptoms isn't always good. So, you can get cases where someone might have really bad symptoms, but their scans look pretty good, and the other way around where they'll have terrible looking scans, but they may not have any symptoms. So ideally, when you're talking about osteoarthritis, it's that clinical diagnosis where you'll see the changes in function and changes in range of motion, and that they will have symptoms as well, irrespective of what their scans show.
So if someone comes in with new hip pain and they had a scan and it shows that there's osteoarthritis on the scan, is that enough for you to diagnose them with hip osteoarthritis, or is there a certain time frame there that people need to have the condition for?
No, there's no time frame. So it's because the change, if they've got pain in their hip, and for OA, it's usually sort of in that anterior hip and groin region, but they might also have it elsewhere. So they might have it in their buttock, they might have some pain in their lower back, in their lateral hip. And the other thing that's with arthritis, with hip OA, that's really interesting is you can get pain further down the leg. So particularly laterally, so they can have pain in around the lateral knee, down the lateral shin, and even into the ankle and the foot. So if they've only had that pain for a week or 2 weeks and they have the changes on the scan, that probably the disease has been developing for a long time. So those changes that you'll see on a scan will have probably taken many years to get there, but this may be their first presentation of pain. And so you don't need to have had pain for 6 months to have that diagnosis of osteoarthritis. When we do our research projects, we typically probably include people in our research who might have had pain for longer. So we would typically say at least 6 weeks. But clinically, no, someone presents with pain and they have that presentation. I think even in a new episode, you can probably in your mind think it's arthritis. Whether you say that to the patient straight up, you may or may not, depending on, reading the patient and how likely they are to potentially, catastrophize that or become really stressed about that. But, for a clinical diagnosis, it doesn't have to have been there for a set period of time.
Yeah. And I love later on to talk about whether or not people should be very stressed out when they get that diagnosis, because I think it is a scary one. So I'm glad that you sort of brought up this idea between radiographic or OA on imaging versus just clinical. When someone does have a image that looks like they have osteoarthritis, but they don't have any symptoms, are you more concerned about that person than the one who has a healthy looking hip on imaging? Or is the person with that image of an osteoarthritic hip more likely to get arthritis in the future? Do we have enough research to say that?
It's a really good question. So I think we have to think about that as that person is at risk of developing symptomatic or clinical osteoarthritis. So there's not really any research that's been done that has followed people over time who have no symptoms but have x-rays that show signs and then followed them to see if they develop symptoms, because that would require you'd require many, many thousands of people to get enough people who had the changes on their x-rays to then be able to follow them to see if they. So it's a really hard and impractical research project to do. But I think you can be pretty confident in saying if someone presents to you and you happen to just see their hip x-rays for some reason, even though they don't have pain, and they have arthritic change, I think you can think about them as being at risk of arthritis. So it's then a question of how do you tell the patient that, and how do you broach that conversation? I think it's important to broach the conversation, but do it in a very non-scary way. So, you can say to them that your x-ray does show some signs of changes that might be consistent with developing arthritis in the future. You don't have any pain. Let's not worry, but, look out for things like the onset of pain or reductions in range of motion. And then you can use it as a tool to really encourage them to try and live as healthy a lifestyle as they can to try and reduce that risk. So, ensuring that they have do their best to have a healthy body mass, do their, eat a healthy diet that perhaps promotes an anti-inflammatory condition, try and maintain, meet the WHO physical activity guidelines. So try and, do that 30 minutes of moderate to vigorous exercise every day. Ensure that you're doing muscle strengthening twice a week with perhaps a focus on hip and trunk and core and leg strength, and doing everything you can to reduce the risk of that perhaps becoming symptomatic hip arthritis down the track.
Okay, so we're sort of talking into prevention a little bit and risk factors. The image, it's, maybe or may not, this will eventually result in having arthritis. It's a little bit difficult to say right now, again, largely because of how impractical those types of studies are. But is there anything to point to in a patient's history that may make you a little bit more cautious that they may be more prone to develop arthritis in the future?
It's a really, really great question, and it's a really important question, and I think you can get a lot of very valuable information just from asking a good subjective examination that'll give you some good clues about the patient's history. So genetics is a really strong one. And so always asking about a family history, do your parents or brothers or sisters or grandparents, have they had hip pain? Have they had a hip replacement? It's a really, really common one. So genetics is a big one. Then the shape of the hip, so morphology can really predispose someone to hip osteoarthritis. So probably the two biggest morphologies that we know of that are a risk factor are CAM morphology that we see in hip impingement or FAI syndrome, where you have that extra bump of bone on the femoral head-neck junction, and then hip dysplasia, so where you primarily acetabular dysplasia, where the hip socket is shallow, so the hip's undercovered, or the hip socket might be anteverted, so it's pointing forward, so there's less coverage of the hip at the front. So those two hip shapes definitely increase the risk of someone developing hip osteoarthritis. So you can ask them if they come in, do you have or have you been told that you have hip dysplasia or hip impingement? If they have x-rays with them, you can have a look at those as well to see if they have those morphologies that do predispose them. And then the other big risk factor is an activity-based risk factor. So we know that people who do heavy manual work are at an increased risk of developing hip osteoarthritis. So asking them what sort of work they do or they've done. So things like farmers or manual labourers do have an increased risk. And then people who have competed in sport, who have played high-impact sport at a high level in their younger years, are also at an increased risk. So if someone's been an elite athlete and played a sport, a high-impact sport, so, football might be a classic example, there is an increased risk of them developing hip OA. But the flip side of that is that sport's also really protective from a general health point of view. So there is an increased risk with that, but we absolutely don't want to stop people playing sport because of that risk. Because while the relative risk is increased, which means people might, have a 2 or 3 times greater risk of developing hip OA when they're older, the absolute risk is really low. So it might be that, 1 in 100 people who didn't play sport will develop hip OA, and 2 in 100 who did play sport develop hip OA. So there's still that 98% who did play sport that don't develop hip OA. So while the risk is increased, it doesn't mean that it's a certainty, and we have to weigh up the benefits versus the negative things. And then the other thing that is an increased risk factor is we don't know about physical function in terms of muscle weakness and things, but we think that might be a risk factor. We're actually doing some studies at the moment to try and determine that. And then being overweight is also a risk factor for the development of hip OA. But the problem with that is that it sits alongside other comorbidities, so things like diabetes and general poorer, more, worse health. And so is it the being overweight that's the increased risk, or is it just that the people in that situation are not don't have as good a general health and don't do as much physical activity, and are more sedentary. So there's those confounders that we don't really know. Is it the body mass that's the risk, or is it the other things that go alongside that? So they're sort of the main risk factors that you can look into for someone who presents.
There's a lot to unpack there, but I think I just want to clarify first by asking, is that risk for radiographic OA or for clinical OA? Do we know that? Is it different on a case-by-case basis for the risk factors?
That's such an important question. It's mostly radiograph. Those studies have mostly been done in radiographic OA. So some of them have been done in symptomatic, or combination of radiographic and symptomatic. So the morphology stuff is mostly, so the dysplasia and the CAM morphology studies have mostly been done in radiographic, but in saying that, it's not just an increased risk for changes on scans, it's also a risk for having a hip replacement later on. So hip replacement in a lot of the studies is the outcome that they look at. So does having these things increase your risk of having a hip replacement later on? So that would definitely be considered clinical or symptomatic, because hopefully most people are only having hip replacements for symptoms and not just because they've got changes on imaging.
Yeah, I was going to say, I hope that's not the case.
So
let's try and go in order of those different risk factors there. So when it comes to like CAM morphology, as you said, that is often a key component of femoroacetabular impingement. But just because you have the CAM morphology, it doesn't always mean that you get hip impingement, right?
Exactly.
Now, do we know if there's a difference in the risk for someone who had a CAM morphology and maybe asymptomatic or non-symptomatic impingement versus someone who had like clinical FAI, or is that too difficult to determine? Because as I'm asking this question, I realize how difficult that study would be to conduct.
It's a good question, and actually we are doing some studies looking at that at the moment. So my colleague, Dr. Josh Heary here at Latrobe has led a lot of the studies that have looked at the imaging findings in people with hip and groin pain. And he's done some really, really nice cross-sectional studies, so looking at the association between the hip shape and the early arthritic changes, so things like changes to the cartilage and changes to the labrum. And what he's found in his studies is that, and he's looked at it in people with pain and without pain, and what he's found is that the morphology definitely increases the risk of having the changes in the cartilage and the labrum. So having the shape means that you're more likely to get those arthritic changes on a scan, early arthritic changes on a scan. But that's the same whether you have pain or not. So that risk is the same in people with hip pain and people without pain. But what we have to remember is they're young people. We don't know yet whether the people who don't have hip pain at the moment, when we follow them over time, might become the people who do have hip pain. So we're actually doing that study at the moment, but we haven't followed people for long enough to be able to answer that question. So there's definitely an association between the shape and the changes on imaging. At the moment, it's the same in people with pain and without pain, but we're just doing it at one point in time. So as we follow those people for longer, it may be that those who don't have pain when they're 21 or 22 or 25, by the time they're 35 or 45, they might have pain and they might be they might end up developing arthritis, because the signs of arthritis sort of develop progressively over many decades. So we are doing that study, but we have to follow the people for a long time to get the definitive answer to that. Some Dutch colleagues of ours that we collaborate close with at Erasmus Medical Centre have done some similar studies, but they've done it in older people. And I know that they have some work that's going to come out soon that has followed people for a longer period of time that suggests that maybe they're having pain as well as the bone shape eventually does increase your risk. But
having pain as someone who's younger.
Yeah, so having impingement, having the hip impingement syndrome where you have pain means that you might, over a longer period of time, you might be at an increased risk of developing hip arthritis than someone who doesn't have the pain. So, but we still don't definitely know the answer. But we do know the shape definitely increases the risk, and pain, having the hip impingement syndrome might mean you're at a greater risk down the track than someone who doesn't have the syndrome, doesn't have the symptoms. But we don't have the definitive answer yet. Does that make sense? Hopefully it's not confusing.
It's not. So when do I have to check back in with you? When the results are published? It's going to be 10, 15 years?
Yeah, probably in a few years' time. Yeah, I reckon.
Okay. All right. So if someone comes into the clinic and they have hip impingement, are you already thinking about educating them about their future risk for OA? How tight is this correlation? And is it such a strong risk factor that we should be educating anyone that we see with a CAM morphology?
We should know. We should not be educating anyone we see with a CAM morphology. So if you're like working at a sports club, for example, and probably 3/4 of the athletes that you look after, if you're treating, in a football team or a hockey team or something like that, they will have CAM morphology. So you don't need to be, scaring all those young athletes with CAM morphology to say we need to change your activity and all of that to reduce the risk. But if someone presents clinically, so they've come to you because they do have symptoms and they do have CAM morphology, I think it's a good educational point around maintaining a really healthy joint. So the way I would like to frame it is that, yes, look, we know that because you've got that bone shape, you do have an increased risk down the track that you might develop hip arthritis. But we have to remember it's only a might, it's not a definite. And we think there are probably things you can do now that might reduce that risk. So use it as a good teaching point. It's about maintaining a healthy joint inside a healthy body. So, being a healthy person and trying to maintain good body health generally, and then within that, just looking after your joints. So not scaring them and stopping them from doing things. I think that's the absolute opposite to what you want to do, but encourage them that being active actually helps preserve your joint, and exercise is actually important. It actually makes your joint more healthy rather than less healthy. So don't stop exercising. Often most people will probably need to do more exercise than what they're doing to maintain joint health.
And not to muddy that advice too much, but at the other end of the spectrum, as you mentioned, it seems that high loading activities or really strenuous jobs may increase the risk as well. But at the same time, being sedentary wouldn't work in someone's favor. It seems like there's maybe somewhat of a paradox there. Is there like an optimal or a more appropriate amount of loading that people should experience throughout their life to prevent or to reduce the risk? Or is it the type of loading?
I think it's a combination of both. And look, to be honest, we don't have the data in the hip at the moment to really be able to say definitively what the right amount of load is. But we can draw from what we know about the knee. It seems as though in the knee that there's a really optimal, like right in the middle is the right amount. So it's like most things, in life, that it's the Goldilocks effect. So if you do absolutely nothing, it's bad for you. If you do way too much, it's possibly bad for you. But I think it's just encouraging people to meet. I really like to use the WHO physical activity guidelines as a minimum standard to meet those and build on that. But I think if you look at the studies that did look at the increased hip OA risk, they were done in elite Olympic athletes, and so they were people who were training probably 40 to 50 hours a week at high intensity. So that's a lot, and most people are not going to go anywhere near that. So I think you're going to be very, very safe if you stick in that. If you look at the studies that have looked at the protective effects of physical activity on general health, so on mortality, so the risk of dying for all causes, on things like heart disease and those sorts of things, the sweet spot seems to be anywhere between 150 minutes a week, so the WHO sort of minimum guidelines, but all the way up to say 600 minutes a week, which is 10 hours a week of physical activity. So that's a reasonable amount. But I think anywhere in that spectrum, and anywhere from probably 20 to 30 minutes a day up to an hour, 2 hours a day of moderate intensity physical activity is going to be safe. We have no evidence for that, but that's the way I interpret what we know about other conditions and other joints, that doing that sort of good amount, try and aim for an hour a day. And moderate exercise, it can be things like jogging. If someone likes to run, then we think running is probably protective for the joints. We know that it is actually, in moderate amounts, is probably protective for knee joint health. And if you think about what the hip does when you run, the hip doesn't go into any of those extreme ranges of motion when you run. It's very much in a neutral position. So, if you're doing most sports that don't ever take the hip into the extremes of range of motion, then I think you're going to be pretty safe. The other question you asked, Noah, was about the type of load, so not the amount, but also the type. And again, we don't have any evidence for that, but I think excessive load right at the extremes of range of motion in some people might increase the risk. So the extremes of range are probably, deep flexion and rotation positions. But again, we don't have any evidence for that. And if someone can go into those positions comfortably without pain, I would be they enjoy the sport, they're doing what they love, I'd be very hesitant to stop someone from doing their sport, because it might increase their risk in the future of getting arthritis.
I do jiu-jitsu, and that is basically the sport to a T. Extreme ranges of hip motion. So I'm going to keep going.
And high impact as well. Yeah, absolutely. Right. But if you're not getting pain, I would strongly encourage you to keep going. I think, you might get a concussion. There's other things that you're probably more at risk of, nasty bruises and concussions and things, perhaps, rather than getting hip arthritis down the track. So, and all sports great. I think every sport is good, and it's our job as clinicians in the physical therapists, physiotherapists, is to try and make sport as safe as we can for people so they can keep doing it.
Absolutely. So we're talking about that, about people continuing with their sport and staying healthy and active. And we've spoken about some specific effects of the hip. It's probably a good idea to load the hip appropriately, but we've also touched on how health also seems to be relevant. And I think that is something that maybe isn't as commonly known in the general public, that just our general health is also very important, because I think I heard, I forget who said it, so apologies to whoever did, but they said that systemic effects and systemic health can sometimes manifest locally in one area. And I think this is a perfect condition to explain that. Would you agree with that?
100%. Yeah, absolutely. So if we think about the person who comes in to see us with hip osteoarthritis in the clinic, generally speaking, they're probably over 35, 40 sort of would be the younger end that you would see all the way through into older age. And they do often have comorbidities. So they might have diabetes, they might have cardiovascular disease, or other comorbidities as well. And Obesity and overweight is another one. And what we actually think is that those conditions are all potentially established and then prolonged by a systemic sort of your body being in a systemic unhealthy sort of inflammatory state. And my colleague Professor Peter Bruckner talks a lot about the effects of sugar on inflammation and how our diets now have too much sugar in them, and whether that's we haven't studied that in people with hip osteoarthritis, but our centre here is doing a clinical trial looking at the effects of an anti-inflammatory diet on knee osteoarthritis. And I think that general body health is really, really important. So as physios, when we're treating someone with hip osteoarthritis, the things that we can do to address that are, I think, really encouraging people to do general physical activity. So anyone who comes to see me in my clinic, I'll address the problem so it's usually a hip problem, their hip, if it's hip osteoarthritis, I'll address the local factors. But I'll also talk to them about general health and encourage them to do general physical activity. So that's not specific for the hip, but it's equally as important is to get them out walking or bike riding or swimming or doing some other sort of general physical activity that they can do that doesn't aggravate their pain, and meeting those WHO guidelines as a minimum benchmark, 150 minutes a week of moderate physical activity. That's the little minimum amount they should do. And then if I think that their diet is a problem, like I'm not a dietitian or a nutritionist, so I don't have qualifications in that area, but I'm very comfortable to refer them to resources or to people where they might get the advice that they need. So there are some really good resources out there that talk about inflammatory diets and anti-inflammatory diets, and you can refer them to your professional colleagues as well who have expertise in the dietary stuff. So so it's important, I think, that we don't have to address everything ourselves, but what we should be doing is be able to identify if there is a problem with someone's diet and then refer them on to the appropriate person to help them resolve that. But absolutely, the general health is as important as the specific joint health as well, and we should be addressing that as best we can.
Hey physios, I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are that Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it. I love that point. So it seems like there are things that we can address, and that arthritis isn't, something that you're necessarily doomed to have. You did mention genetics at one point. Do we know of any potential genes that if someone has them, then, we can say with absolute certainty that they will get arthritis? Or does it seem that in almost all cases, we have the ability to be optimistic about this and say that there are modifiable things that could reduce your chances of getting arthritis?
That's a good question, Noah. It's a curly question. I don't know that we know that there are specific genes that if that gene's turned on, you're definitely going to get arthritis. I don't think the studies have been done, but to be honest, I'm not 100% sure. I do know that family history definitely is related to the risk of osteoarthritis. But again, in family history, there's so much in there. It's not just your DNA, it's also the environment that your family, because families tend to, generations of families tend to follow a similar trajectory through life. So they're the environmental family history risk factors as well as the genetic family history risk factors. So I think that you can probably say, my guess, I'm just guessing it's probably a combination of both, but it's not doom and gloom. So if someone has a family history of osteoarthritis, again, it does increase someone's risk. So it means you are more at risk of ending up with symptomatic hip OA, but let's do everything we can, use it as an opportunity to really try and promote a healthy lifestyle and general person health as well as hip joint health, and minimise that risk as best we can.
Okay. So how about when someone actually does get arthritis? Is it now doom and gloom? Because that's, I think, how a lot of people feel when they're diagnosed with it. They feel like that's their trajectory now. Can we encourage people and reassure them that they can get better? Do we have to educate them saying that, things are progressively going to get a little bit worse? So if someone first comes in with that diagnosis, how is it that you educate them?
I think it's really important to tell them that there is a lot you can do to probably slow the progression of arthritis down. And our Norwegian colleagues have done some clinical trials where they've followed people up for the long term, and they've found that by doing a good quality 3-month strength and range of motion based exercise program, you can reduce the risk of having a hip replacement and delay hip replacement for up to 6 years. So there's some good evidence that a good quality sort of physio-led exercise program can definitely delay the need for hip replacement. We in the GLAD Australia program that I'm part of, our data from our annual report, which we've actually just finished, one of my colleagues has just finished writing, shows that the GLAD program, so that's a 6-week education and exercise program, it improves pain and quality of life by about 30%. And people who come into the GLAD program with hip arthritis thinking that they're going to need to have or want to have a hip replacement, about 3/4 of them after the program say, actually, I've changed my mind and I don't think I need a hip replacement anymore. So exercise, a good quality physio-led exercise program can definitely reduce the likelihood of needing a hip replacement or delay it. Which is, I think, really positive and really, really important. And it's really great for people to know. The flip side of that is to not, if you get to a point, because a lot of people who do come in with hip arthritis have tried, you'll try those sorts of things and they might not work for those people. And they might get to a stage where their quality of life is so impacted, their pain is so severe that they feel like they don't have any other choice other than a hip replacement. And for a lot of people, that's true. They probably don't. I'm counselling people often who we've tried everything and they're at the point where they literally can't sleep because of pain. They're, taking lots and lots of really strong painkillers. I think in that case, don't be scared of a hip replacement if you've got to the point where that's what you need. Hopefully we want to try and, stop people from needing that and delay it. But when you get a number of people with hip arthritis will get to that point where they need a hip replacement. A hip replacement is a very successful procedure. So 90% of people who have a hip replacement will have a really, really good outcome. There's a small number that won't, but I think a lot of people are like, I shouldn't have a hip replacement and I'll put it off for as long as I can. And I've had patients who have perhaps put it off for 2 or 3 years, and in those 2 or 3 years, their general health has deteriorated so much because they're in so much pain that they can't do anything, that the negative effects of not being able to exercise and not being able to do anything are much greater than the potential negative effects of having had the surgery. So, of course, as physios, we want to really help our patients not have surgery as much as they can. We don't want people to have unnecessary surgery, but it is necessary in some people with hip arthritis, and that we can support them to have the best outcome possible if they get to that point.
Is it then a fix where they get the surgery and then they don't have arthritis anymore? Because as you were saying earlier, there's a lot that's going on in arthritis. It's not just the cartilage, for example. It's even the surrounding muscle tissue.
Yeah, that's a great question. So there has been some studies done that follow people after joint, mostly in the knee rather than the hip, but I think we can correlate a lot of the knowledge we have from the knee over to the hip. So a couple of my colleagues here at Latrobe University, Christian Barton and Millie Bell, have done some studies in people with knee arthritis where they follow them to see if they do the GLAD program, for example, does that mean that after that they increase their physical activity? And other colleagues have done studies that have shown after joint replacement that actually the joint replacement and the GLAD program as well will help people's symptoms and pain, but they don't become any more physically active. If they're left to their own devices, they don't become any more physically active than they were beforehand. So it does. So the joint replacement takes out the old joint and puts in a new joint, so to speak. It's not a natural joint, obviously, but people will still need to be guided to improve their local strength around the joint and then their general physical health and physical activity as well. So you can't just put it in and then they're fixed. They will definitely need guidance and encouragement and rehabilitation to be able to improve all of those other things afterwards as well.
Got it. So let's rewind a little bit and talk, before the replacement. You mentioned that we could delay or reduce the chances of needing a replacement with a good quality exercise program led by a physio. And this is where I struggle, and I'm hoping you can help me out. And I know it's a tricky question, but I struggle with what a good quality program means for hip osteoarthritis. Mainly because I'm not sure why exercise tends to help people with the condition, because we see so many different forms of exercise that can be helpful for someone. So in your mind, what are some key characteristics of a good quality program?
The first and most important characteristic is that the patient likes it and is happy to do it and has the resources to be able to do it. It's feasible for them to do. So I think that's the number one thing, is making sure someone enjoys it, because if they hate it, they will not do it. And fair enough too, I wouldn't do something if I hated it. I'm like, I'm not going to do this. So I think that it has to be something they like and it is feasible for them to do in their environment. So, depending on the cost, all the different things you need to be able to do an exercise program. So let's assume they like it and it's feasible. Then I think a good quality program has to consist of an element of strengthening exercises, probably 2 to 3 times a week. And that generally is probably 30 to 40 minutes of strengthening exercises a couple of times a week. And then an element of general physical activity most days of the week as well. So when I have a patient come in, I actually sit down with them and say to them, right, you're going to have to do your strengthening exercises 2 to 3 times a week. So you tell me which days, and you actually schedule it into their calendar or into their diary like they would anything else. There is some evidence that shows that small group exercise or supervised exercise or doing exercise outside of the home you might get better engagement. But in saying that, for some people that's not feasible. So in setting them up to do something at home, I think it can be equally as beneficial if it's feasible for them. So you need to do that sort of the sort of strengthening exercises twice a week at a minimum. And with the strengthening exercises, you want to be looking at strengthening up the big hip muscles. So looking at strengthening hip extensors, abductors, flexors and adductors, and then also looking at strengthening up the trunk as well. So we know that the trunk controls the pelvis and the acetabulum sits in the pelvis. So strengthening the trunk is a really, really important element. And then not forgetting the other lower limb muscles as well. So quad strength is particularly important, hamstring and calf strength. So just a general lower limb strengthening program can be really, really effective. So if we're talking specific exercises, I'm a big fan of things like a hip thrust or a bridge with a heavy weight on the pelvis, and using TheraBands and cables to strengthen, the muscles around the hip. For the trunk, simple exercises like crunches or mini sit-ups or planks can be really, really effective as well. And those things don't put the hip into a position where it hurts, because that's the other thing with hip arthritis, is if you're doing a lot of movement, particularly into the extremes of hip flexion, it's going to irritate their pain. So you need to make sure you're giving them exercises that don't irritate their pain. So general lower limb and trunk strengthening is really important. And then that general cardiovascular exercise as well on most days of the week.
Got it. There's a trend that I've noticed in a lot of conditions where strengthening programs can tend to be helpful for them. But we don't always need to see someone have a higher ability to produce force than they did before in order to get out of pain or to have maybe better functioning. And I know you like to use the handheld dynamometer in your practice and
Mm.
likely track people's strength over time. And I'm a huge proponent of strengthening exercises. I think it's good for people to get stronger. But do you think it's essential that people with hip osteoarthritis need to have a higher ability to produce force in order to get improvement? Or is there something else about the strengthening exercise that seems to be leading to those better outcomes?
I think it's a good question. I think it's actually both. So I think a lot of people with hip arthritis have such a low baseline strength. Like if you're measuring someone on a handheld dynamometer and, they for their hip extensors, for example, their strength is 30 newtons, that's just not enough strength for anyone to do anything. So I think for a lot of people with hip OA, their baseline strength's really low. And in that case, you probably do need to actually see an improvement in how much force they can generate. But it doesn't mean they need to have huge amounts of improvement. Even just a small improvement can make a difference. So I think that is important for some people where their baseline strength is really, really low. But I totally agree, there's lots of other benefits of strengthening exercises that are not just changes in muscle, the ability of the muscle to generate force that you see. It's about confidence. A lot of the strengthening exercises will give people to do, they might have to stand up on one leg and that sort of thing. So it's about it improves their balance. It makes them less scared to move, gives them confidence to put their joint into different positions. It allows them to feel like they can do more general physical activity. So if they feel like they're doing exercises to make them stronger in their legs, they might then have the confidence to go for a walk because they trust their leg strength more. So, and then there's the effects of strengthening exercise. Like we do know that strengthening exercise actually has an effect on general health. So there's some good evidence that shows that strengthening exercise can improve conditions like diabetes and cardiovascular health and can actually reduce the risk of cancer. So we're assuming that that's probably mediated through a reduction in inflammation. So I'm guessing that probably a similar thing happens with arthritis, that strengthening exercises themselves will mediate that effect, that inflammatory effect, and reduce inflammation. And strengthening exercises can also, it increases the muscle metabolism. So that can be an important part of weight loss as well. If someone is obese or overweight, that potentially the benefits of the strengthening exercise might be in changes to body mass as well. So
Right. So it's not so simple that, they're in pain because they're weak, but I think
no,
it's
that's
still
right.
certainly worth getting stronger.
Absolutely. And the weakness, I think, is part of potentially for some people, partly why they're in pain, but it's not the only reason. But absolutely, but the strengthening exercises will have a huge benefit beyond just making that muscle more able to generate force.
Right. And there's also the aesthetic achievement that you can get from it as well, which may be important for some people.
Yeah, totally, 100%.
I know that you have to start prepping for another meeting, but before we sign off here, is there anything else that you think that we missed that you feel is really important for clinicians to keep in mind when they are managing someone with osteoarthritis in the hip?
It's a good question, Noah. I think probably something we haven't touched on that's important is these people are often in a lot of pain and they come to us because of their pain. So as clinicians, I think don't be scared to engage with someone's physician or their medical practitioner that they may need additional medical management for their pain. So for some patients, we have to get them started on some sort of analgesia or anti-inflammatory medication guided by their doctor for their pain to reduce enough for them to be able to engage in the exercise program. So I think don't feel like it's up to us to manage their pain by ourselves, that we can definitely collaborate with our physician colleagues, that some patients whose pain is severe might need additional support to help reduce their pain. So I think making sure we collaborate with the whole team is really, really important to address their pain alongside the exercise interventions and all those things that we're really good at doing.
I think that's such a good point. And I can imagine that there's some listeners that probably had the idea in their mind of, what about manual therapy then for hip OA?
Yeah, manual therapy is a good point. So there's been some studies done that have looked at manual therapy, and what they found is that adding manual therapy to exercise in the studies doesn't doesn't improve people's outcomes beyond that of exercise alone. But what we have to remember is that there was only so much time in the appointments in the study. So if you add manual therapy in, it was taking time away from the exercise. So in saying that, I find myself for some patients that using manual therapy as a way to reduce pain to then enable someone to engage in exercise can be really, really helpful. So I do use manual therapy. On my patients who present with hip arthritis. It doesn't become a priority over and above the exercise, but it can be an adjunct that you might use in some patients to help reduce their pain and improve their range of motion and give them the confidence that they need to then be able to go and exercise. So don't be scared to use manual therapy, but it shouldn't be the only thing that you're using.
Definitely. Okay, got it. Thank you so much, Jo. I really appreciate it. I think that was a really, really helpful conversation for a lot of people. I think it was a nice overview into osteoarthritis and probably dispelled a lot of myths, and it has a lot of practical solutions in it as well. So I'm really happy you joined me today.
Thanks, Noah. Thanks for having me.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.